Hey, everybody. I'm super excited because I get to talk to an expert, a friend, and a nationally, if not internationally renowned doctor about a subject that I think is so important, not just to folks in urban areas, but most important to folks that use drugs, that live in rural communities. And we got to figure this one out because we've got the tools and resources to address HIV, substance use disorder, and STIs in our community. And I don't know that we're always making the best benefit and use of them. So I'd like to introduce my friend. I hope I can call him a friend. He'll tell you in a minute if that's true. It's probably I probably just lied. He's not my friend. He'd be like, I don't know you, but I think he does. And I'd like to introduce to you Dr. Leo Moore. Dr. Moore, introduce yourself to the people.
Nice to meet you for the first time, Tony.
Right, there you go. Right. So, Dr. Moore, tell the people who you are and what you do.
Yes. So I'm Dr. Leo Moore. I'm an internal medicine, lifestyle medicine, HIV medicine physician. I am the medical director for LA County Department of Public Health's Clinic Services Division, where I oversee four public health clinics and our teleprep team as well, which is a team of nurses and providers and administrators that provide PrEP virtually. So providing PrEP through phone and video. All of the visits are done through phone and video. I'm also a member of the Presidential Advisory Council on HIV and AIDS and have been a member of the council for the past 2 years and the co-chair of the Stigma and Disparities Committee.
Wow.
So, this work is my passion. I've been doing this work for over 15 years now. Happy to be here with you today.
Perfect. And I really do want to thank you because, my first question for you may seem like a simple question, especially with somebody with your background and your expertise. But my question is, what is PrEP? And I know we're here to talk about DoxyPEP, but I want to talk about pre-exposure prophylaxis and what it means and what it is, but especially what it is and what it means for people who have substance use disorder, because that's a population of people we deal with, and they don't really talk about PrEP a whole bunch.
Great question. So what is PrEP? So PrEP stands for pre-exposure prophylaxis. And so when we break that down, before exposure to HIV. So this is medication that is taken to prevent HIV in the event that a person is exposed to HIV. And there are two formulations currently. One is an oral formulation, and there are two medications for that, Truvada.
What does that mean? That means pills? I have to take a pill?
Yes. There are two pill versions. So there is Truvada and Descovy. And then there's one that's an injectable version. So that's an injection into the buttock. And that one is called Apretude. And Apretude is taken once every 2 months.
So that's a shot in the tuchus.
It's a shot in the tuchus. Definitely.
Okay. All right. So there's a pill version and a shot version. Yes. And is there a difference in the two?
The difference in the two is just the way that they're being administered. You have to take the pill daily for the majority of people. Some people actually do what's called event-based PrEP. So that's people who aren't having a lot of sex, right? They take 2 pills within the first 24 hours of having sex, 2 to 24 hours. Then they take an additional dose 1 day later, an additional dose after that. But the majority of people are taking the pills daily. So you have to take the pills daily, or you take the injection every 2 months. Both of them have very high efficacy. So
what does that mean? Efficacy means that it works, right?
It works very, very well. 99% or higher efficacy. So 99% or higher protection in those who are taking the medication as prescribed.
So wait a minute. So you're saying if I don't have HIV, right? I don't have it. I don't have HIV. I don't have HIV or AIDS, however people, because it's HIV is what we talk about today. Mm-hmm. If I don't have it and I take this pill or I take this injection, I have a 99% prevention rate of getting HIV if I'm sexually active with a person who may have HIV.
Correct.
Okay. Now, here's the thing. Now, some people may like get upset with my next question, but I'm going to ask my next question because this is the question I get asked.
Okay.
Is PrEP just for gay people?
No, PrEP is not just for gay people. And I'm so glad that you asked that question, Tony, because I feel that I'm constantly wanting to educate people on the fact that PrEP is not just for gay men. PrEP is also for women as well. PrEP is truly for all people who have had a bacterial STI or those who are having
A
condomless
STI? A STI? What's that?
bacterial sexually transmitted infection.
Oh,
So, if they've had gonorrhea, chlamydia, syphilis, for example, or if they're having condomless sex with multiple partners, so they're having unprotected sex with multiple partners, they should consider PrEP. I often tell people that your sexual health is your responsibility. And I think that even for those who are in relationships can give a false sense of security. Not always, but for some, they can give a false sense of security, and people may be at risk for HIV and other sexually transmitted infections and not be aware of that.
but I don't know. Many people may not remember her or know her, but her name is Ray Lewis Thornton. She's a black woman. Was the first black woman living with HIV. Was on the cover of Essence magazines. And I don't even know if Ray remembers saying this to me, but I remember we had dinner one night, and she said, "Heterosexual woman," and she said, if the penis isn't in your pocket, you don't know where that penis has been. And I thought about that for the longest time. I was like, that's a real strange way to put that. I said, but the truth of the matter is like you don't, because guess what? People lie. So it's important to, I think, have your own protective factors. And do we see PrEP being used by the majority of folks who are sexually active? Because my understanding is that it's something like, I think like something like 90% of white gay men who can access PrEP or something like that are accessing it. But people who have substance use disorder, black women, black men, same gender loving men are not accessing PrEP at the same rate. Is there a reason why we don't see PrEP uptake in these other communities as much?
So I think there are multiple reasons. So one we know is medical mistrust around the use of medication and also accessing healthcare. Period. We know that is a challenge. We also know that another challenge that is not addressed enough is concern around long-term side effects from medications. Having true and deliberate conversations around the risks and benefits of taking these medications as well. And I find that those conversations are best had when I'm in a small group setting or if I'm having a conversation directly with the patient so that I can truly address what is your concern. For example, a concern I hear quite often is, oh, well, this is going to mess up my kidneys. This is going to cause me to develop kidney disease. And I can then respond to that and share that we monitor your kidney function every time that you get a refill for the medication. And if your kidney function numbers begin to rise, then we can switch you to another medication. Like we are monitoring your body. But the risk of HIV in those who may be, engaging in those behaviors that can increase their risk is higher, so the benefit is better to take the medication than not for many folks who are concerned about their kidney or their liver, because we're going to continue to monitor their body and can help protect them against any side effects.
So it's not just willy-nilly. You're not just walking up to the pharmacy and saying, give me this treatment opportunity, and you go off into the sunset. There's monitoring that goes along with it.
There's baseline testing and monitoring. So that way we can say, when we started you on this medication, this is what your creatinine or your kidney function showed. Now we're checking it every 3 months and we're able to monitor it, so that way, if it does start to increase to a level that is concerning, then we can switch the person to another medication.
Okay. All right. Well, okay. So that's the basis. All right. That's what PrEP is. Now we're gonna take a slow journey to Doxy, but because we need to make a couple of pit stops along the way.
Mhm.
So one of the things you may not know, I think actually you may have heard me say it, but even though you tell people we're not friends, but I know that you've heard me speak a couple of times, and that I always say this little ditty about Appalachia, the Appalachia region, right? That there's a train that's roaring through Appalachia. The engine of that train is the Oxycontin crisis that many of us know. But the reality is that that's now a multi-drug use opportunity. That's the engine that's driving the train. The next train car on that train is hepatitis C. Next car, hepatitis B, hepatitis A, educational attainment challenges, economic development challenges, workforce development challenges, with the caboose being HIV. I think we've added a sidecar called syphilis. There's a syphilis outbreak in this country that we really need to be addressing. But in this case of this train, it's laden down with coal, the environmental impact, the economic impact of coal on the entirety of the region. Now, and I bring this train up at this moment is because of this. I have a core belief, and I can't prove this, but I believe it anecdotally, right? Or for those of you that what I believe it. I believe it based on what I see, the surroundings are around here. Is that what I've got to figure out is how to get MAT, medically assisted treatment providers, those that provide buprenorphine, Suboxone, methadone. I got to figure out how I get them to increase their HIV screening, their hepatitis C screening, but also their PrEP uptake, right, for their clients and their patients, or their PrEP education. Why? Because I believe the 20 to 25% of people living with HIV and hepatitis C in this country that we can't find, I believe a large percentage of them are sitting in or passing through those MAT providers. So help me talk to those MAT providers. What can MAT providers do to scale up PrEP?
Mhm. Great question. So I'm going to liken this to my work in public health centers. My clinics are public health clinics. We do not provide all primary care. We provide sexual health care. We provide PrEP and PEP, DoxyPEP, as you mentioned as well. But we see ourselves as a gateway to primary care for those who do not currently have a primary care provider. And that's the same way that I see the MAT providers, because those patients are going to the MAT provider regardless of if they're going to primary care or not, right? And so that is their entry point. And we know that, as you mentioned, that train is really the syndemic. It's really all of these different, co-occurring epidemics, right? And so the best way for MAT providers to support the patients that they're seeing is to, have that syndemic eye, have that eye on what are the challenges that are affecting my patients the most, that are actually, impacting not only their drug use but their life, and how can I help to address those? How can I help get them maybe started on PrEP and get them connected into primary care to continue? Maybe the MAT provider, prefers not to be the provider who's consistently prescribing the PrEP, but creates that pipeline into primary care to surrounding providers, for example. Or maybe they say, hey, I will start with the HIV screening and the syphilis screening, and I will ensure that they get connected to get treatment. What have you. I think there's so many models that can be considered, but first it's getting them to recognize that this really is an issue, that they have a key role that they, can play to address it.
And let me ask you this about them. Can they do this in a telehealth kind of way? I think many of them think we're already maxed out. We don't have the staff. We don't have the time. We don't have the capacity. Can they partner up with like telehealth organizations or what nurse practitioners or physicians that might be able to do this work with them?
They definitely can. And in fact, because patients are often going into MAT providers, they're getting lab work done already, right? So the lab work could be done when they're going in, and then they could have a virtual visit, with a nurse practitioner or with one of those organizations that's already, doing PrEP across the country. A few come to mind for me, like Mister or Q Care, or so partnering with an organization that already does some of this telehealth work could be like a great and natural fit for increasing access.
Can we? Yeah. So I want to. Thanks for that, because I want, but I want to talk about that for a second, and we really are going to get to what we're here about is the DoxyPrep thing. I know you're like, girl, you said we talking about DoxyPrep, so but I think this is all kind of the lead up to it, right? Because I think DoxyPrep is again another thing that we may have left a bunch of people behind on prep, and now we got I want to bring everybody along.
Tony, I'm not going to say that we may have left them behind. There are a lot of people that we have left behind. And in the same way with DoxyPEP, I'm concerned that we will continue to leave people behind.
And this is what I want to spend a minute here about, right? Is that you mentioned a couple of sites, Mr. and you mentioned one other. What the population of people that we represent, that we work with, that we work for, that we work on behalf of, those people, when I pull up that Mr. site, I don't see those people. And I wonder how much of a turnoff that would be if I sent them to that site. And that's not to say that those sites don't have an intrinsic value for specific populations. I think they do. But where do I send the farmer from one of the 423 Appalachian counties? When he pulls up or she pulls up the Mr. site, they're gonna be like, "It's not for me," even though the information may be for them. How do we get more sites that are reflective of broader communities? How do we? Where do people in Middle America and rural America go to see themselves in these campaigns or in these opportunities?
Well, I think that's a great question. My thinking is, although we don't see those communities in Mr. and Q Care, I think there's a business proposition to be made to existing, organizations like those and businesses like those to say, there are communities that are missing on this site that, could increase your revenue, right? If you were to address that and to make it, a bit more open and more welcoming to those different communities. So, my challenge with us thinking, well, where are other organizations is, that's going to take those other people taking an interest in this, right? Whereas we do have some organizations that have an interest. How can we potentially massage that in order to be able to use it for this extended or, broader purpose?
Right, because I mean, and I think just from I'm a MBA. I'm not an MPH, right? So from my business framework, I'm like, if you've eaten up 90% of a market, if a 90% of a market thereabouts has access to the thing that you say everybody needs access to, but you've got none of the other market having access to it, it seems to me you change your marketing strategy to get more of the community to use your product. So it means something's got to change. That's just me, especially to the Mr. site. I mean, if we could see, make it look more like farmersonly.com and not like, it's an advertisement just for the Castro. I mean, I'm just being very honest. I'm just being transparent. When I go on, I can't, on one hand, I've got somebody saying to me, is this a gay thing? And then I'm like, no, it's not. But then I send you somewhere and it's a gay thing. We want.
No, I get it.
Yeah, I mean, I think we've really got to I think we've got to put more resources, opportunity, and attention into and being intentional about what we really are trying to do and what we're trying to say. Now,
well, I will also say that this could be an opportunity for a local FQHC or a local, community-based organization that works closely with practices as well. I mean, no one is going to know your community better than the people who are from your community, right? So, I think there is a lot of power in that as well. So that's just something to think about. Are there organizations there that already have, a number of patients on PrEP? And it may not even be a large number, right? But they have patients on PrEP. They have some best practices for this region, and they could maybe partner, with some of the MAT providers, right? But you need a champion, I think, on the healthcare side, and you need a champion on the MAT side. All you need really to start is, I think, one champion on each side, right? Because they know the key players within each of those areas.
Right. Well, I mean, I think that I think you just gave us a plan, right? We need community champions on each side to kind of move this forward. And I think the Mr. People need to look out for a phone call and an email from me. But I'm just going to say, and no, and nobody wants that now, do they? So you know, so let's keep this train a moving. Uh, so what we know is that rural communities have a high rate of substance use disorder. What we know is that we have a syphilis outbreak in the United States of America. I think that this is where it is critically important that we start to have this conversation about doxy and what does it mean? What is doxy prep and how is it different than prep?
So it's a great question. And I want to ensure that I say DoxyPEP because
Pep,
this is
not prep.
slightly
It's not.
different.
So I'm saying it wrong. I'm doing it wrong. It's doxy pep. So
It's DoxyPEP.
okay.
And I'm going to draw a comparison between the two. So when I talked about PrEP being pre-exposure, you're taking that medication daily or taking the injectable every 2 months to prevent exposure. So before exposure. Post-exposure prophylaxis, you're taking the medication after exposure to prevent yourself from getting, in this case, an STI. That's what DoxyPEP does. So it's doxycycline post-exposure prophylaxis. And it works really well against gonorrhea, chlamydia, and syphilis. So against syphilis and chlamydia, it decreases the risk by 70%. And against gonorrhea, it decreases the risk by 50%.
Wow. Now, I mean,
And
but
so,
I mean, do people get gonorrhea anymore?
oh, people definitely get gonorrhea. People
Really?
definitely, yes, they do. Chlamydia, of course, is the most common, but a
Right.
lot of people are still getting gonorrhea. And so the medication has to be taken within 72 hours of sex. And the person does not have to know if the other person has an STI. So, they finish having sex and then they take their DoxyPEP. And it decreases the risk that they will get an STI. And I think this is so important, Tony, because one area that we haven't gone is the congenital syphilis.
Well, that's
It
what. So
is an
that's so what.
outbreak that we need to.
And a part of the reason why I wanted to get to you right away is
Mhm.
that in West Virginia, what a lot of people don't know is I think it was in the month of June we had our first case of congenital syphilis, and that's what. And I think that people think about syphilis, gonorrhea, and I think that they really think men. And I really want to have this conversation about why it's critically important for women to be having a conversation and not just heterosexual women, women who may be sleeping with other women. I
Mhm.
think it's important that we have this conversation across people who are using drugs. I
Mhm.
mean, I think this is a conversation that it requires a national response with the quickness. I know Dr. Tim Harrison is doing a bunch of work around syphilis and developing new syphilis protocols and responses for the nation. But
Mhm.
I think that we are in with a ticking time bomb that a whole bunch of people aren't paying attention to. We've
Mhm.
got these outbreaks in West Virginia. We've now got this syphilis challenge across the country. And I think if those two things converge, we've got a huge problem. So
I
tell
agree.
me how people access Doxy Pep.
So in order to access DoxyPEP, you need to do that through a primary care provider. So that primary care provider is also going to test the person for HIV and STIs. And then they write a prescription for doxycycline. So it's 200 milligrams of doxycycline. Usually they come in 100 milligrams tabs. So you're taking 2 tabs within 72 hours. The DoxyPEP guidelines, I think, are so important because in certain communities, we know that the state may not already be up on the latest regarding HIV and STI prevention, right? So in California, back in, I want to say it was maybe March or April of 2023, California put out guidelines. And as soon as they put out guidelines, I worked to implement DoxyPEP in our clinics, right? But many states have not put out their own guidelines, their Department of Public Health, right? So that's where these national guidelines really come in and play, because now you have guidelines that West Virginia can use. You have guidelines that many of the other states across the Appalachia, can use in order to push for more access to this in primary care practices, and through community-based organizations that work closely with practices, and so that way more education is done and more access is then provided.
So let me now I want to talk about PrEP and PEP for a minute. In this way, in this context. How do you pay for it?
So also, before I go there, I want to just mention HIV PEP, because I think that that's one that we don't hear enough about as well. So you've got HIV PrEP, HIV PEP, and we've got DoxyPEP. So just briefly about HIV PEP, or post-exposure prophylaxis. So that's the process of a person taking 2 medications once a day for 28 days after an exposure to HIV.
Wait a minute, Dr. Moore. Wait a minute, Dr. Moore. I gotta back our train up. Choo choo. Right? So all right. So wait a minute. Gotta get this right. So make sure the people understand. What you're telling me is that there is a pre-exposure. I can take a pill or get a shot for HIV. Talking about HIV, not STI, HIV. So I can take a pre-pill or injection, right? And now what you're telling me is that there's a thing for HIV that I can take a post-exposure if I think I've had an exposure to HIV. Okay, so now I'm gonna say it this way so we'll be able to cut this up in a different way when we rebroadcast. Dr. Moore, explain to us pre-exposure and post-exposure prophylaxis for HIV. Go.
So we'll start with HIV pre-exposure prophylaxis. That's the process of a person taking medication before they've been exposed to HIV to prevent HIV infection in the event that they're exposed to HIV. And it can be taken either as a pill or as an injection. The pill is usually taken daily. The injection is taken every 2 months, and the injection is in the buttock. So that's HIV pre-exposure prophylaxis. It's also highly, highly effective. It decreases the risk of HIV up to 99% or more in people who are taking the medication as prescribed. So that's HIV PrEP. Now we'll go to HIV PEP, or post-exposure prophylaxis. So this is the process of a person taking medication after exposure, or after they think they've been exposed. They do not have to know that the person has HIV. They just have to have concern that that person may have HIV and they had condomless sex with the person, or the condom broke, what have you. So they take 2 medications for 28 days. They have to start it within 72 hours of sex. So once sex ends, that countdown begins. You've got 3 days from the time that you've had sex to take that medication. And that medication has been shown to decrease the risk of HIV by 60% or more. And we will never be able to do what's called a randomized controlled trial, where we, are testing HIV PEP versus a placebo or a sugar pill, because it's unethical. We know that HIV PEP works, and based on the data that we have observationally, meaning we've kind of watched how it's worked over the years, so it is a standard that is available to everyone who has come in contact or is concerned that they've come in contact with HIV within the past 72 hours.
Wow. Okay, so now I need you to explain to me DoxyPEP for STIs. Okay, so other than condoms, is there another way that there's a preventative mechanism? Or this is what I'm going to use the DoxyPEP for, right? PEP for, right? Okay, now I'm going to let you explain it, because you said your name. You said Doctor was your first name. Go ahead.
Well, my first name is Leo, but
For the rest of the world now, your first name is Doctor. I don't know. They're not going to know. I don't know what his name is, but it was Doctor somebody. Go ahead.
But regarding DoxyPEP, so DoxyPEP stands for doxycycline post-exposure prophylaxis. So it's the process of a person taking doxycycline after exposure, or again, concern for exposure to an STI, and specifically to gonorrhea, chlamydia, or syphilis. So this medication has been shown to prevent gonorrhea in 50% of cases. So it's 50% effective in preventing gonorrhea and 70% effective in preventing syphilis and chlamydia. It must be taken within, why did I lose that for a second? It must be taken within, shoot,
72 hours? 48 hours.
it is 72 hours. Sorry.
I'm here with you. I'm here with you.
Within 72 hours to prevent those STIs. Mm-hmm.
So here's and I know we are getting ready to wrap this up, but my question for you is, who can use this? Whether we're talking about the HIV pre and post exposure prophylaxis, or whether we're talking about doxycycline for STIs, who can use it and who should be using it?
So who can use it for HIV PrEP and PEP? Everyone can use it who is HIV negative for HIV PrEP and PEP. For DoxyPEP, it's a bit more challenging because the data only is currently supporting it being used for people who are men who are having sex with men and transgender women. But the guidelines do also allow for a provider to talk with the patient and determine, if it's, for example, a woman, right, a cisgender woman, or
what
a
does
woman.
that mean? What does that mean? My people don't. My people don't know what you're talking about.
Mm-hmm. Or a woman who identifies as the sex that she was assigned at birth.
Gotcha. Okay.
So it says female on her birth certificate, and she identifies as female.
Okay.
So in that group, because the data didn't show effectiveness in preventing STIs, the provider would have to decide with the patient, should we give you this medication anyway? And that would be more of an off-label indication, meaning we're giving the medication in a way that it's not regularly prescribed because we see a benefit to it. And in my opinion, there are many people that I could see a benefit for. For example, say someone's a sex worker, and they're engaging in sex very regularly. They may also be having anal sex as well. And so I think, this would be a great person for DoxyPEP. I also would think, someone who may be using drugs as well, who is of reproductive age, that DoxyPEP could be a great option for them as well. Remember, we're trying to prevent congenital syphilis as much as possible, so those are the types of people that I would think, okay, this is off label, but the benefit of this is much higher than the risk in preventing syphilis, and ideally then preventing any congenital syphilis cases in that woman. But I mean, we would also have to make sure that the person knows you've got to take this medication after you've had sex within 72 hours.
Wow. First of all, I want to say thank you. I don't know about the people that are watching this or the people that are watching in the future, but I sure as heck learned a lot today. I think that we have a lot of tools that are available to us. And I want to make sure that, again, part of I like to say that our job at Community Education Group is to bring resources, opportunity, and attention to the Appalachia region. And this is a critical resource. As I stated earlier in this call, that, I believe it was last month, or maybe it might have been May, but I think it was June, we had our first case of congenital syphilis in West Virginia. But it wasn't the last, right? It was the first. I think as we're looking across multiple populations, people with lived experience around substance use disorder, I got to figure out how to reduce the number of likely cases of HIV, the number of likely cases of hepatitis, and certainly the likely cases of syphilis, gonorrhea, and other STIs. We used to, back in the day, they would call them STDs. So some of my old folks might be like, what's that? The difference is STI, STD, basically same thing.
Same thing.
And so, what I want to ask you as my last question, it's a big one. What can we do as regional or community or national organizations to help facilitate educating a population about the availability of these treatments, these biomedical responses?
Mhm.
What can we do to better educate these populations who aren't the what I call the majority of populations receiving education? Tell me what I need to do.
You need to go to the people. Go to where they are, I would say. Go to events that there is not an expectation that there will be any education. And the reason I say go to those types of events is people's guards are then down. They're in a place where, let's say it's a community fair, and you're just sharing information in the same ways that, there may be other booths and there are fun things that are happening as well. Like it's a way to just engage people in their own environment, an environment that they're comfortable in. So that would be one approach. I also think that there is an approach for educating providers as well. So one approach that I like for educating providers is doing provider detailing as well, because those providers are then having those one-on-one conversations with patients. And so provider detailing is something we did a few years ago where we worked with ex-pharmaceutical reps and had them go out to provider practices and take a few minutes and talk to providers about the latest regarding PrEP. But this one could be, regarding the syndemic, for example. So, coordinating with them to see, can we have someone come during their lunchtime, for example, and speak with you, for 30 minutes about just updates on, what we're seeing in Appalachia and how we may be able to work together, to prevent those different STIs, HIV, and other diseases.
Yeah. Thank you for that. Dr. Matt Christensen, who is the head of the West Virginia Department of, I think it's health hygiene and something else. But Dr. Matt, he really said to us long ago that he believed that one of the best models might be to use the model of many of the pharmaceutical companies using community liaisons to go in and do something very similar. Bring in a lunch and talk to the staff that we have to do it. We have to figure out how we're going to get into those. That's because that's a whole other social network, right? And I believe that that's what we have to do: infiltrate social, sexual, drug sharing, familial networks with education and extract information out. How do they want information? Where do they get information? And I think it's a reciprocal process that we all have to be in. But I think the most important thing is that we've got to get folks in a place where they are tested, linked to care, where we can do prevention care and treatment on demand, where people need it and where people are. Dr. Leo Moore, you are my friend. And I don't mean that in the who sings that song, "You Are My Friend," but I don't mean it. But I want to thank you for taking time out of your day and out of your practice to really share with the people of the Appalachia region and the others that will take a look at this either now or looking at it now, or that will look at it in the future. I value you. Thank you for the work that you do. And thank you for the commitment that you've made to HIV. And people don't understand that 30 years into a crisis, 30 years into an epidemic, many people have turned away. But there are people like you that
And
remain
you.
and that remain committed to HIV and understand that it's not just one population, but it's a national problem that we have to deal with. So thank you so much for sharing your knowledge with us. And we look forward to working with you and seeing you in the future. Thank you.
Thank you so much. It's such an honor, Tony. So thank you for having me. And I look forward to future conversations as well. And of course, however I can be of support, I'm here.